Yeah. Hi. Hi, all. Thank you, CCI, and thank you, Dr. Sri Krishna and Dr. Vijay Kumar, Dr. Ravi Dosi, and whole CCI team. And today, I wish you all a happy new year. And today, we are going to discuss on cough and incontinence. And we have a esteemed panelist among the group here, and a physiotherapist, Dr. Janvi, and two pulmonologists are there. Neurophysician is there, and we are lagging behind. So we will take it on, and let's start the first session. Over to you, speaker. Thank you.
Very good evening, one and all here. I wish everyone a happy and a prosperous new year. And I would like to thank Dr. Krishna sir and CCI for this wonderful opportunity. I'm Dr. Asha Fathima, Pulmonologist. I'm here to give some inputs and insights on cough and urinary incontinence. And let us move into the topic today. And the objectives would be definition, prevalence of cough and urinary incontinence, and pathophysiology, types, sex specific contributors, and the specific lung diseases and the mechanism of urinary incontinence related to cough and its management. So, cough is a protective reflex. It is nothing but the forceful expiration against the closed glottis. And our thing is to deal with a chronic cough today, which is nothing but cough persisting for more than 8 weeks in adults. And urinary incontinence, it is involuntary leakage of urine, which causes social or hygienic issues. And cough induced urinary incontinence is nothing but because sudden increase in intra-abdominal pressure which exceeds the urethral pressure and causes involuntary leakage of urine. Coming to the prevalence, according to the Indian scenario, there are few studies quoted from south part like in Kochi and northern India as well as in Maharashtra, where they have checked the risk factors for the incontinence, urinary incontinence, and cough being the predominant risk factor among other risk factors. And the most predominant type of urinary incontinence is stress compared to the other types. And when we try to find out the studies on males with cough, chronic cough and urinary incontinence, there are not much studies done. And this study is taken from SDM Hospital in Dharwad. Here it shows almost 40% of male are also getting affected with urinary incontinence, and they do have moderate or severe symptoms of COPD. This study is being conducted in the COPD patients. So, 40% male who has urinary incontinence also had moderate or severe symptoms of COPD. So, this mandates the routine screening of such complaints in the male patients in our routine clinical practice. And coming to the mechanism of cough, for the cough reflex to be initiated, the irritants can be anything like thermal in the form of cold air or any inflammatory substances or like anything irritating the airways when it comes in contact with these cough receptors, which is usually located in the ear canal and nose, larynx, trachea, bronchi, pleura, pericardium, and the diaphragm. They do like causes influx of the calcium and by the pannexin receptors causes release of the ATP. So these receptors are responsible for each and every kind of irritant, and this further causes influx of calcium and sodium and action potential. Further, the sensory input is carried by the vagus nerve to the nucleus tractus solitarius and paratrigeminal nerve, and from there to the higher cough modulating areas. So it is this area which can either suppress or which can hypersensitize the cough. Yeah, it happens at this level. And coming to the phases of cough, generally it begins with the glottis opening on activation of the cough reflex. So whenever the glottis is open, there happens the deep breath and followed by the glottic closure and expiratory muscle starts to contract. And it is at this phase where the urinary leakage starts to begin, but it is more predominant in the expulsive phase. Coming to the mechanism. of cough and normal continence. So whenever there is a cough, there happens the increase in intrathoracic pressure leading to the increase in intra-abdominal pressure. But the pressure is equally distributed to the bladder and the urethra. So, followed by pelvic floor muscle contraction along with the external urethral sphincter contraction, leading to the continence, which means the urethral pressure here will be higher than the bladder pressure, maintaining the continence. Any alteration in this leads to the urinary incontinence. Coming to the types of incontinence, we'll see first about the stress incontinence. This happens due to any kind of damage to the pelvic floor muscles or the supports like endopelvic fascia or the pubourethral ligament or urethral hypermobility or internal sphincteric deficiency. So all these generally those endopelvic fascia and the pubourethral ligament damage usually happens during the childbirth or prolonged labor, vaginal delivery, or using forceps, those kinds of manipulations. And in intrinsic sphincter deficiency, like it is like those two ends won't attach together, the mucosal coaptation won't happen. This may occur because of the estrogen deficiency, which can happen in menopause. These are the etiology for the stress incontinence. So there is no support from these structures and no equalization of pressure between bladder and urethra, and urinary leakage happens. It usually occurs after a strong trigger, and there will be like a small leakage. The amount of urinary incontinence, like the amount of urine is only very little here. But when we come to the urge incontinence, it is mainly because of the detrusor overactivity. So initially we have to rule out the neurological causes, followed by the diabetic, and next COPD itself can stimulate the detrusor activity. This is because both share the vagal sensation. Also, hypoxia or any kind of inflammatory substances can irritate the vagal sensation or can increase the parasympathetic activity, causing the detrusor overactivity. Here, they will have a strong urge to urinate, and it will be large volume leak for as well as the nocturia. And here, people do get benefit with the modest anticholinergics in this urge incontinence. In stress incontinence, both the cough part as well as the pelvic floor muscle training both has to be given. And coming to the overflow incontinence, this is mainly because of the urinary retention. So what happens here is, in case of bladder outlet obstruction or any kind of opioids or the anticholinergics, the urine tends to accumulate and there will be like a continuous dribbling or weak poor stream. Opioids like morphine can cause this, but it is more beneficial than this symptom because it constitutes a very minor proportion of urinary incontinence. And coming to the neurogenic incontinence, it can be either increased detrusor activity or it can be decreased detrusor activity. And here they do have the urge, but the urge is controllable and with the presence of the neurological signs. We also do have the functional incontinence, which is nothing but there will be urge which is not controllable, and the absence of the neurological signs, as well as this can be differentiated from the urge incontinence by the absence of the nocturia also. So urge incontinence and functional incontinence both happens in COPD patients, but functional incontinence can happen in any kind of respiratory issues, but mainly the patient will be elderly or hospitalized, and encouraging mobility will help in overcoming those issues. The picture depicts the same, the stress incontinence and the overactive detrusor muscles. Coming to the sex-specific contributors, here in females, it is mainly because of the pelvic floor muscles and its support, either the endopelvic fascia or pubourethral ligament and the estrogen, those reduced coaptation. These are the main reason for the urinary incontinence, and it happens with a trigger. So whenever there is a cough on laughing, talking, those times this gets aggravated, and there is no equalization of pressure and leading to urinary incontinence. Um, and males, it is mainly because of the intrinsic urethral sphincter failure. This happens in post prostatectomy patients where the external urethral sphincter is damaged. So the control over the bladder neck is damaged, and hence there is likelihood of urinary leakage. So females do present typically with features of stress incontinence. So there will be partial improvement or response to cough and pelvic floor muscle training. But here in males, pelvic floor muscle training is much beneficial than the cough treatment if patient is presenting with post prostatectomy surgery or procedures. And coming to the disease specific causes and pathophysiology and treatment. So, in the chronic cough and asthma, leading to the urinary incontinence is mainly because of the airway inflammation and hyperresponsiveness. So, this causes cough clusters, which means there will be repeated cough episodes without any gap in between for breathing. This causes increase in intra-abdominal pressure, and the pressure is transmitted to the bladder neck. And there is also a term called preemptive pelvic floor contraction, which is nothing but whenever the cough, like expiratory muscles, intercostals or diaphragm, intercostals or abdominal starts to contract, the pelvic floor muscles also starts contracting. So this is called as the preemptive contraction of the pelvic floor muscles at the initiation of cough. So this doesn't happen whenever there is a repeated cough. The workload over the muscle is more, and it becomes fatigue, and there is no preemptive contraction happening. And here the urethral pressure will become lesser than the bladder pressure, constituting to the urinary incontinence. So the pharmacological management will be focused mainly upon the control of asthma symptoms, as well as managing comorbidities like GERD or upper airway cough syndrome. If it is refractory, then we can consider adding low dose neuromodulators. And non-pharmacological treatment initially begins with education and then trigger avoidance, as well as cough control therapy, like cough suppression therapy. So we have to say them that cough is a voluntarily, you can control the cough. They have to understand that, and we have to educate on that. And then they can have either sips of water, or they can soft throat clearing can be done, and other laryngeal relaxation exercises, or like diaphragmatic breathing and pelvic flow, both this cough and continence strategy, which is nothing but both patient has to inhale through nose and like exhale through mouth, along with the pelvic floor contraction at the same time. And they like, but they have. But the thigh shouldn't be more contracted whenever they are attempting for the pelvic floor contraction. And coming to the COPD, these are the studies which are articles which states that cough and urinary incontinence is equally seen in men and women, and it is not related to the severity of COPD itself. So this urinary incontinence in a COPD patient is itself a comorbidity than the drug-induced effect. So also people in general practice, it is also recommended to look forward for the male patients with urinary incontinence, which is usually underreported. And coming to the pathophysiological link, right from the exposure to the clinical features, everything is linked to the mechanism of urinary incontinence in COPD patients. So from smoking, which causes connective tissue damage or the muscle dysfunction, So there will be reduced strength in the pelvic floor muscles. And dyspnea, there won't be like proper neuromuscular coordination. So there won't be preemptive contraction and leading to delayed pelvic floor activation. Chronic coughing, which causes increased intra-abdominal pressure. As I said, it increases the workload over the pelvic floor muscles. And abdominal breathing patterns, which means here the patient use more of the accessory muscles of respiration, and hence there won't be synchrony between the diaphragm and the pelvic floor, and no preemptive anticipatory contraction. If like in these patients, if a muscarinic antagonist are warranted, it is better to go with the LAMA than the SAMAs. Coming to the non-pharmacological treatment, begins with education, trigger avoidance, and cough suppression, and otherwise diaphragmatic breathing and huff cough. This is the same: inhale through nose and exhale through mouth. And huff, huffing technique is like inhale a little deeper than usual and blow out the air in 3 even breaths. And there is also other technique like yawn sign technique, which is nothing but whenever you yawn, there is this space in the throat is more, and it reduces the tension in the larynx. And coming to the chronic cough in ILD and urinary incontinence, this is mainly because it is a restrictive lung disease. So, cough is initiated at the low lung volumes and they require higher expiratory effort. So, for the expiratory effort, abdominal muscle recruitment is more, and the pelvic floor load is increased. And this causes the impairment. There won't be any synchrony and there won't be any anticipatory pelvic floor contraction. Also, it causes laryngeal hypersensitivity and other conditioning factors, other conditions like age or deconditioning and steroids also causes reduced pelvic floor support. And urinary incontinence is the study states that urinary incontinence due to chronic cough in interstitial lung disease patients is like equally seen in male and females, and it is related to the severity of the underlying disease. Coming to the pharmacological management, in terms of antifibrotics, pirfenidone has much better control in cough reduction and reducing urinary incontinence indirectly than the nintedanib. And since in ILD, it is supposed to we have to target both the cough part as well as the pelvic floor muscle training. The cough, for the reduction of cough, there are studies stating other drugs are also being tested and it was effective also. So, coming to the nebulized sodium chromoglycate, which acts over the, which prevents the release of mast cell mediators near the nerve endings. So this has shown effectiveness in reducing the cough frequency. And thalidomide, which inhibits TNF alpha, and it is also the central cough suppressant. It also has shown to improve in cough. And INF alpha lozenges moves towards the anti-inflammatory process, and it has showed the cough reduction. And pirfenidone, as I said earlier, but there is no such role of azithromycin. And also, use of NP120 also has shown this is the nothing but the NMDA antagonist, and it is also acting over the central acting cough receptors. And it has also showed the 50% reduction in the average cough. And the non-pharmacological treatment is the same for everything. Chronic cough and pulmonary hypertension and urinary incontinence. This happens because the lung compliance is reduced because of the increased vascular remodeling. Other factor could be interstitial edema or vascular dilatation transmit impulse to the bronchi and it causes activation of cough receptors. So it can either activate mechanoreceptors or the chemoreceptors and also the cough hypersensitivity. So frequent coughing can reduce the pelvic strength or it can cause it to be fatigue. and there won't be any coupling or the synchrony between these things, so leading to the like bladder pressure more than the urethral pressure and leading to the urinary incontinence. In pulmonary hypertension, if the cough is not addressed, if patient is repeatedly coughing, it can lead to the increased intrathoracic pressure, which can cause decreased venous return and worsening dyspnea or syncopal attacks. So pharmacologically, we can aim giving low dose neuromodulators and non-pharmacological cough control therapy in pelvic floor conditioner training. Chronic cough in lung cancer and urinary incontinence. The prevalence of cough in lung cancer is almost more than 60 percentage, and it is not related to the cancer characteristics or the underlying comorbids like COPD, etc. But it is also stated that like almost all people will respond to the anti-cancer therapy. So once when the patient is not responding to the anti-cancer therapy, then we have to think of the other comorbid conditions like any airway disease, heart failure, or anything like a complication of a malignancy like post obstructive pneumonia or pleural effusion, or is it due to chemotherapy, immunotherapy, or radiotherapy induced? Those parts has to be addressed. And more likely, these people do present with the stress and the urge incontinence. And here we go with the demulcents, because all the mucosa would be damaged because of the chemotherapy as well as the radiotherapy. Then opioids or local anesthesia, gabapentin, amitriptyline, thalidomide, NK1 pathways. Initially, this drug was used for cancer-induced vomiting, but now they say can also be tried in cough. And non-pharmacological techniques like education, trigger avoidance, cough suppression technique, and pelvic floor exercise training. So take-home points would be like COPD patients can present with urge incontinence as well as the functional incontinence. In urge incontinence, there is modest benefit with anticholinergics, but not in functional incontinence. And diaphragmatic breathing or huffing also helps more in COPD. In asthma, mm, we can try initially with ICS or bronchodilators. If refractory, after controlling all the comorbid conditions, then we can attempt the low dose neuromodulators like gabapentin or pregabalin. And non-pharmacological techniques, of which huff technique is the low expiratory flow, which is mainly useful in lung cancer as well as in COPD. Thank you. I would like to hand over to Dr. Janki ma'am for the further session.
Good evening, everyone. Now, I would like to go further with cough and urinary incontinence and how physiotherapy will be helpful for the same. So, basically, the cough, as we know, it is a protective reflex that is commonly seen in respiratory diseases and it is useful for the secretion clearance. The mechanism involved for coughing that is the deep inspiration followed by closing of the glottis, and after that there will be a forceful expiration that is done by abdominal and pelvic floor muscles. So next is urinary incontinence, that is involuntary leakage of urine. Most common type, that is a stress incontinence. It is an involuntary leakage of urine that occurs during activity that increases intra-abdominal pressure, and that is the reason which will further increase the weakness of pelvic floor and abdominal muscles. So the coughing that increases intra-abdominal pressure, and after prolonged coughing, the muscles will not counteract the pressure, and that results in a leakage of urine after strenuous activities like coughing, sneezing, or even with laughing. And that impact higher on the patient side, that increases anxiety and fever, as well as that reduces the self confidence, that reduces social participation of patient and ultimately affecting the mental health. How we can assess? So there are two domains by that we can assess the patient. First is subjective, in which we will consider the history of stress incontinence, history of any respiratory illness, and other than that, patient may have obstetrics and gynecological history. For the objective assessment, we will measure the pelvic floor muscle strength and cough stress test. For the medical management involved, treating the cause of coughing, that is the treating the respiratory illness, or even if patient is having any gynecological issues, patient can also go for the treatment of the same. And other than that, physiotherapy is the important part for the management. Physiotherapy involves mainly the strengthening of weak muscle, that is pelvic floor muscle, and the commonly used exercise or is Kegel's exercise. The pictures are showing the steps, and further we can go for increasing the pelvic floor muscle strengthening with biofeedback. Biofeedback is the technique which involves use of mechanical devices to improve the real-time information of the patient's data. EMG biofeedback and biofeedback with sphygmomanometer are the common type in a clinical trials. After that, we can also go for abdominal muscle strengthening, and we can also go for core and breathing technique, that is by neck technique, that involves active support after the coughing, that reduces the strain on the muscle and that prevent the further weakening of the pelvic floor. Even we can teach patients to give external support via pillow or via both the hand, and even we can provide binder to support the abdominal muscle in cases of severe weakness. And for the prevention, we can treat the underlying cause. We can strengthen the muscle by advising patient to do the exercise regularly, or even we can consult gynecologist for the further worsening of the condition, that is the prolapse of reproductive organ. That is it for my side. Thank you for this opportunity. And now I would like to pass the mic to Dr. Hirennappa for further discussion.
Thank you, Dr. Asha and Dr. Janvi, for excellent presentation on urinary incontinence and cough. And let's move on to a panel discussion. And so we are already late now. So let it make it so simple. And I would like to welcome Dr. Asha and Dr. Janvi, which you have already heard. And I would like to welcome Dr. Shrutika Thakkar, gynecologist from Mumbai, and Dr. Yash Rana, pulmonologist from Rajkot, and neurologist Dr. Govind also is there in the panel. Let's make this topic more interesting and more practical questions, especially in females. It's very embarrassing. So they don't come, even they come for a cough, their worrisome and bothersome symptom will be urinary incontinence, especially. So I would like to start with most of the time what the pathophysiology and everything, whatever the transmitted pressures which is in the genitourinary system when the cough is cough cough which is really chronic. An acute cough, sometimes if you reduce it, it just goes off for a small infection. Sometimes it can last for longer duration, and these cough reasons we are not looking into it. So we just see how cough impacts urinary incontinence, especially post-viral coughs. We have a lot of post-viral coughs. They will not have much of the symptoms as such. I would like to just highlight one case scenario where we will normally the patient comes, a young patient who is otherwise normally healthy patients, doesn't have any other problem genitourinary and have a seasonal allergy. And I would like to go to and ask this question: if these patients, how do you approach managing her cough if somebody comes with urinary incontinence as a symptom? So whenever they are coughing, they are embarrassed. Their urine just passes automatically, and they are embarrassed to go to outside place, any functions and other things. How do you approach if it comes to a pulmonologist first? I would like to go to Dr. Asha to answer this question. You are not audible, Dr. Asha. Are you able to hear?
Yes, sir. Am I audible now?
Yeah, please.
Okay.
Please go ahead.
So here the anatomy is normal, but the trigger is an allergen. So my differentials will be narrowed down to asthma or upper airway cough syndrome, GERD or drug induced or non-asthmatic eosinophilia also. So I will first confirm those diagnoses and I'll treat the underlying causes. So in case of asthma, I would like to treat with ICS or LABA, and upper airway cough syndrome either with like montelukast or antihistamines or intranasal antihistamines and steroids. And for GERD, PPIs would do better. And for non-asthmatic eosinophilia, they do respond with inhaled corticosteroids. And in case of drug induced, after stopping the offending drug within a span of 6 weeks at least, they would be better from their symptom.
Okay. Thank you, Dr. Asha. Most of the time, if any cough which is more than 8 weeks or which is really impacting incontinence, we normally look at three differential causes. One is the postnasal drip, or one is GRD or a cough variant asthma. We rarely see some other causes like post-viral and other things. Normally, pneumonias and all, they don't last so long. And these are the common, and drug induced, as you said, ACE inhibitor is one of the most commonest things. And that's the way we approach it normally in the cough. And those problems, they will keep on highlighting the incontinence aspect of it. So if you treat the cough, that incontinence will probably grow. I would like to ask Dr. Yash, what are the additional strategy if somebody is coming for cough, and so whatever medication they would have taken, multiple medications, so they would have tried inhaler, antibiotics and everything, so their problem is incontinence. So in that, how do you prioritize and explain them whether cough is the only thing which is causing incontinence? They may not have any much problem. You may not require a gynec consult or a urology consult. As a completion take, we can do certain tests. What are the things you do? How do you address? Because that is that's the thing that they want to address first.
Sir, thank you, sir. Thank you. Sir, first of all, I should tell that should give assurance to the patient first that this is approachable, this is manageable. Patient should understand that this, if he or she is taking care of his cough, managing its cough well, then the further conditions can be addressed. Right. Now, as rightly discussion is ongoing about this patient's cough issues, like diagnosis is proper, allergy is diagnosed adequately and managed by proper immunotherapy, and even the DDs are ruled out. Right. Then we can give trial of this gabapentin and amitriptyline also as a newer medication, as a newer emerging therapies. These drugs may work well. Number one. Number two, always physiotherapy and pharmacotherapy should have a harmony, because both are required for the patient for longer term. Physiotherapy will take time. Muscle strengthening will take time to develop in a proper way. Until that time, pharmacotherapy should be in a good particular, good strength, and a good technique should be proper done good by the patient also. So these things should be taken care. Now, as a part of emerging therapy, these are some speech therapists, and they are delivering good cough suppression techniques. So it's a newer thing in the town, but should be tried. Should be tried. So by all these things, pharmacotherapy, physiotherapy, and behavioral cough suppression techniques, we can give some good assurance to patients, sir.
Yeah, sometimes we, in spite of doing all the things which may take longer time, and how acute or how presentation, what's the role of oral steroids? Sometimes they give injectable steroids, because oral steroids, They are the most important. Sometimes severity of cough, it will not come down. We have seen very severe coughs where X-ray is normal, CT is normal, all the tests are normal. They have some post-viral cough, which is really irritating. What's the role of steroids, in acutely
Sir,
suppressing the.
it totally depends on the exact diagnosis of the cough, sir. If everything is normal, then it might be a cough hypersensitive syndrome where neuromodulators may work well. If everything is normal, still cough variant asthma should be ruled out properly. Pheno should be done properly, right? So all these things, the address should be on diagnosis first, the basic cause of cough.
It's important to treat that cough.
Yes, yes. And then as an adjuvant therapy, we should take a call from physiotherapist.
Okay. So, see, the most of the time we see these are the normal chunk of patients in a young, recently married. These are the women who, but they are really embarrassed,
Yes.
and sometimes they force us that this is too much of a problem. Then the gravity of a problem is more means we normally refer them to a gynecologist. So sometimes we think that it might be absolutely normal. Patient will not come that I have a normal anatomy. Patient will not come that I have everything.
Yes, yes, yes.
We created, but most of
Yes.
the time we should be aware of that there might be something which is there. We just do a normal urine routines and just do probably
So it should be checked with gynecologist also about the anatomy. But
ultra.
the most important part here is counseling, sir. Counseling of the patient according to, regarding her current issues. That is very important to be done, sir.
Yeah, thank you. I agree. I agree with this because sometimes they think that the problem is really, really more, and we need to. Our role is to reassure them. And I would go to Dr. Shrutika Thakkar. How do you rule out? How we send the patients to you with a chronic incontinence? How you approach and rule out? Is there a really what are the tests you do and how they reassure them and have in concurrence with a pulmonologist? What should we ask for you and what should the patients are looking for you when these patients come to you, sir, madam?
So, yeah, sir, that's a very wise thing to do generally for women with incontinence. Because incontinence history is less often elicited by women. So, they will not come out forthright and always mention that, okay, they are having these kind of urinary leaks. And also, incontinence, when it comes, there is a whole range of incontinence that is possible. What we are discussing here, cuff induced incontinence, we call it as stress induced incontinence. So, any rise of abdominal pressure is causing it. Now, this could be because you all are also talking about chronic cough. Now, there can be something called pelvic organ prolapse that can also be there along with the incontinence that is happening. So, when as a gynecologist, when we see this patient, first of all, we try to distinguish stress urinary incontinence from something called as overactive bladder. Now, some of your patients could be elderly, so they could be having a very hyper responsive bladder. So, they will typically present with urgency. So, stress urinary incontinence patient typically says that as soon as I sneeze or cough, the urine leaks out. There is no sense of urgency that these patients have. Whereas an overactive bladder person will say that, I need to go urgently to the washroom, otherwise my urine will come out. So, that's a very distinct thing that we see, so that we can elicit from clinical history itself. With regards to examination, we want to see whether the urinary bladder is descending into the vagina. That is called as a cystocele. So we do a good per speculum examination. We try to rule out whether there is a cystocele, whether there is a concomitant uterine organ prolapse, which is there. There could be a descent of the uterine organ. We also want to rule out urine infections because partly these patients have incontinent, they have some leaks again and again. Their hygiene can get compromised. So they could be having a urinary infection, chronic UTI, which could be aggravating the incontinence. So we do that as well. We want to rule out fibroids or other aggravating problems. So we need to do a good pelvic ultrasound of these people. And one very new thing that probably I believe there is a physiotherapy colleague on the panel. So there is something called as Butterfly IQ Plus. It's a portable ultrasound where we put a probe inside the vagina and we look at the pelvic muscle as a diagnostic tool. dynamic thing. So when the patient is voiding urine, we look in real time. So you can actually make out ki, is there a post-void residue? Is it a leak that is happening? So we ask the patient to walk around, sneeze a little, cough a little, see if the bladder neck is distension. And we can also assess whether there are tears in the levator ani muscle, which is the pelvic floor. So all those things can be done to actually correctly assess.
Okay, ma'am. Yeah, so once you really feel that a proper gynec examinations and new imaging tools like ultrasound, transvaginal examination, ultrasounds or whatever it is there. So we just rule objectively, subjectively, we feel that it might be normal. That is our perception.
Hmm.
So objectively, by simple clinical examination or a simple ultrasound, or we can rule out and reassure them. Sometimes the symptoms will reduce once the cough reduces. That very rarely, how exactly we feel that very few patients in subset, even in the normal patients, we had difficulty in pulmonologist and gynecologist approaching. How exactly we have to get in pitch in physiotherapist for all other things. How exactly we have to go about doing, whether physiotherapist role is there for these kind of patients. I would like to ask Dr. Janaki, in this normal subset of patients, or who really have gynecologist have approached that patients and pulmonologists have already taken care of all those things, then what is the role of physiotherapist in addressing this urinary incontinence, ma'am?
Yes, sir. Physiotherapy is effective in such conditions. Physiotherapy by means of pelvic floor muscle strengthening can improve the strength of muscle, and that counteract the force of coughing, and that prevents the urine leakage and also chances of UTI, which is very frequent in cases of stress incontinence. Other than that, pelvic floor muscle strengthening combined with breathing techniques like controlled expiration at the time of coughing, and another thing that can be done, that prior contraction of pelvic floor muscle at the time of coughing, that can also prevent the force of coughing, and that also prevents the leakage. In such cases, diaphragmatic breathing also can be effective, that reduces the use of accessory muscle, and that prevent the episode of coughing in such patients.
Yeah, thank you, Dr. Janaki. Normally, we don't get, sometimes the gynecologist refer to us. They get the urinary incontinence symptoms, they rule out everything. You are coughing too much, it is due to, you go to the pulmonologist, they will do X-ray, CT, PFT, Speno, all those things. Till this you do that. And sometimes we do all the things, sometimes we don't get into a problem solving. And sometimes cough are very difficult to treat. So they can reduce the quantity of that. Sometimes we don't know certain neurological conditions, like they are subtle, means grossly we will know about the CVAs, so those who are having a stroke, mid brain, the brain stem problems and other things, we normally know. Sometimes we get to know certain patients with neurogenic bladders. Sometimes we get other urologist inputs also we get. So here our esteemed panelist is a neurologist here. We sometimes this incontinence becomes so severe, we normally don't involve the neurologist. So those kind of situations, I would like to ask Dr. Govind Madhaw, how exactly you approach incontinence, and our pulmonologist and gynecologist, how you address them as your colleagues also. Can you just throw the load how exactly the incontinence and your practice?
Yeah. From a neurological point of view, we need to evaluate further, like whether this is truly a cough in incontinence, or there is sometime any underlying urge incontinence or urgency frequency associated with, or predominantly having some subtle neurological symptoms or not. So cough incontinence is usually stress urinary incontinence, but neurological causes must be excluded if some symptoms or some atypical symptoms are there. So first, we would like to take a proper history. So focus on history to look for certain neurological red flag sign, like if the person is saying that she is having some subtle leg weakness or numbness or imbalance or paresthesia around the perineal area, or sometimes he is having back pain, especially lower back pain, or if there is associated bowel incontinence as well, apart from only the urinary incontinence, or if there is any progression of the symptom, means it started only with the cough incontinence, but later started having some other symptoms like back pain or the symptoms I have mentioned above, or if there are histories of perennial injury or nerve injury, especially during the childbirth or any past surgical procedure which might have injured the pudendal nerve or the perennial nerve. So if these conditions are there, then definitely we need to look out for any neurological causes. So if pure stress incontinence is there, then definitely the management, we people are discussing like cough management, physiotherapy management, all these are there. But if there are atypical features which are suggesting some underlying neurological causes, then definitely neurological examination, dedicated neurological examination like examination of the power, examination of the senses, examination of the reflexes, examination of the gait and balance, all these are to be done. If we find any abnormality in these, then definitely we need to go for investigations, like investigation to rule out any occult or subtle abnormality in the spinal cord or the brainstem, depending upon the findings we are getting. So mostly the cough incontinence is a straightforward case without any neurological causes. But if we are getting some atypical features, or if we are getting progression of the symptoms, or if we are suspecting underlying urge incontinence or urgency features also, then definitely the neurological evaluation is warranted. Thank you.
It's normal cephalus, hydrocephalus, and this thing they have a conundrum of headache and incontinence, and these are the features we are not focused on only pulmonology aspects of it, cough and other things. Cough can happen because of brainstem also. Brainstem symptom is also cough. Sometimes a brainstem stroke, a subtle findings. Sometimes we need to get that right when the incontinence is there. That time appropriate referral. Sometimes they keep on coming. We keep on adding medications. So I had a patient who had a cough which is just not going. So it has a brainstem stroke. A neurologist doesn't come into a picture. So we treated, endoscopy was done, ENT evaluation was there. Sometimes we'll feel it difficulty. So those kind of patients, a subtle neurological signs, we should always refer and take a neurology consult in these things. So normally our assumption is a young patient should not have any other problem. Sometimes we can take them for a ride and they will have additional problems. So if the problem is persistent and it is not improving with the regular medications, if you are not able to after the control of the disease of cough, underlying disease can be exacerbated by the cough. Once the cough reduce also, if it is persist, you need evaluations. So I will see. We'll go to the more complex things. So we will go for a complex patients where you really have a problem, underlying genitourinary disease, and which can get exacerbated for a cough. So normally we get to see a general surgeons. They don't operate a patient who is coughing for a hernia. They always take a fitness. They want the cough because the hernia can recur. So these coughs. When we are treating, it's causing it, we feel that your cough we have treated, the incontinence persists after the previous frequent deliveries and weakened pelvic floor. Those are the cases which we need to be careful, where definite multidisciplinary involvement is there. Most of the time we don't normally refer to a gynecologist, or normally we don't refer to, if they directly come to you, we just reassure them, no, physiotherapists are not required. If you address the cough, the problem is gone and done and dusted. So if at all it's after addressing the proper referral and proper inputs from the specialists or experts in treating those symptoms, can add value to our practice also, and the value to the patient also. Sometimes we feel that we know everything as this thing, but certain small these are urinary incontinence are really embarrassed. They don't open up very easily. So I would like to ask the Dr. Asha, how do you optimize cough control before and after surgical intervention? Sometimes they have a cough, they get a fitness from anesthetists also, anesthetists, and anesthetists also they have a fitness issue. So for the cough, and they may defer the surgery, postpone a surgery. We have to come into the picture of telling them there is no obvious pneumonia, there's no infections. So we do our PFTs. How do you take care of these patients when they really need some surgical intervention, or how you manage pre and post op. If you really have some problem
So
and he has ongoing cough and we need to suppress it and hand it over to them.
So prior to the procedure, here the cough like is not just a symptom; it is also acting as a risk factor, which may have effect over the post-operative, the procedural complications also can happen. So it is purely the disease-specific treatment. It has to be the target is towards the disease-specific treatment, and initially we try with if in case of asthma we try with initially ICS LABA, but if it is refractory and if it is not getting relieved and if it is persisting, we may even try to the neuromodulators like low dose neuromodulators. So, as I said earlier, in even ILD, it is the antifibrotic. If we get to have the choice of which antifibrotic will be better for the cough reduction, we can go for pirfenidone. So, it is purely the disease specific, and we have to target towards that. And during the time of surgery, it is like we have to optimize the bronchodilation as well as we have to get relieved the patients from the secretions, and also the post surgical we also have to concentrate on the pain management, adequate pain management, and the same there shouldn't be any retaining of secretions, and the disease specific treatment has to be continued throughout.
Yeah. Thank you, Asha. And Dr. Yash, how you really you postpone the surgery, get the cough under control, or sometimes you are not able to do it optimally, and all the things are okay. We still go ahead with the surgery and use certain medications like morphine and other cough suppressant. Convince them this is very important for them because we can get a minimal cough. We can get a minimal symptom level. Sometimes we will not be able to make a zero cough situations. Those kind of situation, how you take a call?
Sir, we need to do it by any mean. Otherwise, patient will go into very bad complications. So we have to postpone the surgery until we get good control over patient's cough. Otherwise, patient will go into failure of surgeries.
Okay. Thank you. We should be very optimal in controlling. And Dr. Shrutika, what are the surgical options would you consider for, especially for the prolapse and incontinence? What are the surgeries or what are the diseases we just find out in incontinence on your evaluation? What are the because we don't want to get into too much detailing. So, what are the surgeries which we offer for this cough incontinence, and if there is a really a problem, and what are the diseases which we look for?
So you rightly mentioned something that generally this incontinence is associated with prolapse. So, the surgical options depend on whether there is prolapse or there is no prolapse. First of all, it is always after a multifactorial evaluation, after doing a good urodynamic study. First of all, establishing that this is SUI, which cannot be managed medically with the use of drugs like, miragebron or duloxetine or anticholinergics. Then only we proceed with surgery. Now, it is the surgical options are determined by whether there is prolapse or there is no prolapse. If there is prolapse of the uterus and of the bladder, which is called a cystocele and uterovaginal prolapse, then what we generally see is has the woman completed her childbearing or not completed her childbearing. If the woman has completed childbearing, then generally the option is vaginal hysterectomy with anterior and posterior colpoperineography. What we are basically doing is we are strengthening the pelvic floor muscles and the support of the urinary bladder. We are pushing it up. That is what we are doing. If the woman has not completed childbearing, then we do sling surgeries. So we basically put like a device which will lift up the urethra, the neck, and we'll place it little up. So there are mid-urethral slings, and there are transobturator sling surgeries, which are performed generally in one day. It's like a daycare surgery, and it's basically a mesh that places the urethra a little up. It doesn't. It prevents the descent of the urethra with cuff. So definitely when we are planning these surgical options, we know that any mesh which is placed also is after all something that will react to intense cuff. So it always has to go hand in hand with a good pulmonology care, where the cuff has to basically it is the insulting factor that has to go down. If the person undergoes any prolapse surgery or mesh surgery and keeps on coughing, then even these surgical options fail. So the cuff has to definitely be addressed. It has to go hand in hand. And we can also do some like less invasive techniques, like we can put cone pessaries inside the vagina for patients who are not fit for surgery. Then we can put some pessaries in the vagina which place the organ. It prevents descent of the uterus and the bladder. And we can also sometimes now inject Botox in the paraurethral space that gives a little more strength to that area. So these are the various modalities that are currently available.
How often you take urology help, madam? Because we don't have urologist in a panel. So those
Yeah.
situations, I just want for audience sake, how exactly urologist role or urogynecologist role is there?
Yes. So basically, incontinence lot of times is not very singular. Like it may not only be stress urinary incontinence. We can have overactive bladder and urge incontinence, which are going hand in hand. So we take a urologist help when we think that it is multifactorial or there are two, three types of incontinence which are going on. In which case we require a thorough urodynamic study. So it is like we start with a basic thing like a post residual volume of urine. After residue, how much urine is getting retained, and there are some detrusor muscle studies which are called as urodynamic studies that we do hand in hand to analyze whether it is different types of incontinence. A good cystoscopy is also sometimes needed, so that is when our urology colleagues are working hand in hand with us.
Thank you, ma'am. But more so, this definitely a role of physiotherapist in post-op setting.
Absolutely, absolutely.
And in the previous cases it may not be, but definitely when we are addressing the post-op recovery, post-op after the surgical interventions and the healing process for next 3 or 6 weeks, the role of physiotherapists is mandatory. So just in a simple way, how exactly, because certain hemorrhoid surgery, sits bath and other things, so small little things, how exactly to do strengthening, especially in elderly patients, and they use the catheters frequently. They do their own urinary this thing, a lot of infection prone and all. There the role of maintaining the hygiene and getting the whatever surgery is done, that has to be effective, means physiotherapist's role in support system post op is important. I would like to ask Janaki, what exactly you exactly do when a patient comes to post op prolapse surgery, post cystocele surgeries, post treatment of these surgical pelvic floor repairs and other things. What exactly you do in terms of practically, what are the exercises and what are the things we explain them?
In post-operative phase, along with pelvic floor muscle strengthening, we should advise patient for strengthening of lower abdominal muscle and core muscle, which will also support the pelvic floor organs. And we should also advise patient to do these exercises on daily basis for a long-term maintenance, and that prevents the reoccurrence of the same episode.
Okay. Thank you. And any simple you explained in the presentations, Kegels exercise, we may not tend to know too much into it. Sometimes we don't know. So, what are the things we throw a light on? How exactly a simple way? What are the exercises we thought, and what are the simple things in a simple way, so that we understand as audience?
Yes, Kegel exercise is one of the most effective exercise that can be done. In that, we can ask the patient to hold the urine-like sensation, that will contract the muscle, and we can advise patient to hold this for a few seconds, and we can progress this holding time with practice, and that will gradually strengthen the muscle. It is one of the simple exercise which can be recommended by the doctors.
Thank you, ma'am. Psychologist roles and psychotherapy sometimes helps in these kind of patients who are really have a chronic incontinence. That role has also been important. And urologist, they have newer techniques and no new devices which are being there. I talked to a urologist and he have an incontinence. He wanted to put a device that it incontinence to prevent it. So I was something amazed. Those kind of treatment aspects. So especially urology and the neurologic bladder, a lot of patients with previous stroke symptoms, these things, like a thimble bladder. It behaves like our thimble bladder, a small bladder, overactive bladders. Those kind of symptoms, they come with recurrent UTI and incontinence. So their neurologist role post previous, already they have a diagnosed case of neurological problem, maybe a demyelinating disease or a disease which involves bladder. So how exactly the role in neurology in managing and follow up of these patients? It might be a male or a female, and along with a urologist or a gynecologist, or we address the cough for based on the disease per se, whether it's ILD, COPD, asthma. We have addressed that, and it's maybe a GRD, this thing. These kind of subset of patients, how do you manage in coordination with the pulmonologist, sir? Dr. Govind.
Yeah. So first we need to understand whether the condition is having only the stress incontinence part or there is a component of neurogenic bladder. If we are using the word neurogenic bladder, then there are two types of neurogenic bladder, simply the LMN bladder and UMN bladder. Lower motor neuron bladder means the flaccid bladder, which is having high capacity and having overflow incontinence. And the UMN bladder, this means a spastic bladder, means low capacity contractile spastic bladder. Now, we need to understand what is the pathology behind that. If we are using the word element bladder, this means lower motor neurons like the spinal cord pathology or peripheral neuropathy is there, or some muscular problem is there. In that condition, definitely we advise sometimes self-intermittent catheterization, as well as the bladder technique, and the physiotherapy is definitely a pivotal role. As well as when we are having a condition called spastic bladder or UMN bladder, then also the self-intermittent catheterization is the best thing, because the incontinence problem or recurrent UTI problem will remain there unless the primary diagnosis is treated. For that time being, if the expected time of recovery for the underlying neurological condition is less than 1 month or 2 months, then definitely for that time period, indwelling catheter or other methods can be used. But most of the times, the time of recovery is very long. Like if you are getting a condition of multiple sclerosis or spinal cord injury or brainstem stroke, then the patient may remain in that condition for years as well. In such condition, the best practice is the training the caretaker or sometimes the person itself, if he or she is cognitively intact, for the promotion of self-intermittent clean catheterization. And for the lower motor neuron type of bladder or the flaccid bladder, definitely the physiotherapy has got more role. Sometimes like pudendal nerve stimulation devices or nerve stimulation to the sacral area has got some role. But mostly our part is to prevent UTI, what are the measures I have already discussed, and to evaluate the cause of this kind of bladder and treat the underlying disorder that will ultimately take care of the bladder problem itself.
Thank you, Dr. Govind. I came to that bladder surgery, bladder cancer, urinary diversion techniques are also has been used. Sometimes it's really tough when the genitourinary system is really abnormal. Thank you all of you for the esteemed panel. And would you like to how exactly this multidisciplinary collaboration? Sometimes we are individual on our own. We are treating. We think that we don't know the follow up. What exactly happened? They would have gone to some other doctors and other things. Addressing the problem effectively, holistically, and getting into the root cause and appropriate referral. And sometimes those things, small referral, they might remember you for their lifetime. Sometimes they come with a simple problem. We address that properly and send it to proper person. They really adore you. So referral is a good thing to do for a genuine problem. How exactly multidisciplinary collaborations will improve the outcome in this cough incontinence management, sir? So we as a pulmonologist, we keep seeing cough and this thing. I would like to hear from the gynecologist point of view and the neurologist point of view, how we can impact, how we can use you in the management of a cough, sir. It's, in this incontinence related. Which are
So, Doctor, sir, like you rightly have said, like your panel itself is reflecting, cough-induced incontinence is not something that any one faculty or any one branch can deal. It cannot be alone managed by a gynecologist. Like I can't possibly do a prolapse surgery and have the person still coughing, because then my sutures will give away. The surgery will not work only. So a multidisciplinary approach is highly important. The best part is I'm glad that you guys are talking about it, because see, cough-induced incontinence is something that, especially when women are the patients, they are very reluctant to share also to the doctor. You know, your patient could be coming with cough since very long time. She might be suffering from that incontinence, just changing undergarments. Sometimes there is so much social stigma. They might be psychologically also disturbed, but they will not come and tell only that there is any cough-induced incontinence. So I'm glad that CCI, Team CCI, Dr. NH Krishna, yourself, you all are talking about this, dedicating 1 hour to this kind of panel. It is amazing, because awareness and spreading awareness, asking your patient about this, that itself is a very, very good start. And definitely involve all your colleagues, the urologist, the gynecologist, neurologist, because it is always multifactorial. It is seldom unifactorial. No one person can manage it completely. So I'm glad that this is being done, and it's a very wise thing to do, a multidisciplinary approach.
I would like to ask all the panelists to see what are the biggest gaps here, in terms of history taking, as we are evolving into a new era. With we were subspecialties earlier, we have become a specialties, and when we are taking the history and all, when they really come to a gynecologist, we don't behave like a family physicians, or this thing we don't get. So since you have come to a urologist, we get all the urodynamic studies, KUB and everything, and we still don't address the history which precipitated, and all the things might come normal, and so much expenses, and doing evaluation, going to a routine history and taking a simple history properly can solve most of the things, and additional images which are required tailored to the requirement is important. And you first talk to your colleagues or specialists, and that can solve most problem rather than more imaging and more testing. And that's what I feel. And anybody would like to add important point for this topic? I'll go one by one. Dr. Shrutika first, and then neurologist, and Janki. Can you just throw a light, or your last final questions? How exactly we need to be effective in treating this?
So the gaps currently in cough-induced incontinence is, first of all, prevention. So if your patient is having chronic cough, first of all, make sure that, right before this incontinence and all develops, only proper pelvic floor care is advised to the patient. From the gynecological point of view, taking care of the pelvic floor muscles at the time of delivery, at the time of abdominal surgeries, when there is post-operative some amount of cough, preventing it from becoming like a chronic cough is something that we all need to work on, including more physiotherapy, doing it religiously. A lot of times, the physiotherapist will advise the exercises 1 or 2 times the patient will do. And since we are all very keen to give medicines and to do surgical interventions, we forget the fact that exercises are important. Also, lifestyle. So much of the incontinence is because of poor lifestyle and obesity today. Obesity, smoking, all that aggravates this kind of cough-induced incontinence. So working on lifestyle factors is also something that we cannot forget. So I think that would be my last 2 words here.
Yeah, nocturnal incontinence is associated with sleep apnea. Sometimes the sleep apnea in adult also. Sometimes we see incontinence in this thing, bedwetting and all. So this can happen in adults also in sleep apnea. I have seen few patients. So these are simple little things. It's a small, simple clinical clues when we are addressing. Thank you very much. I would like to hear from Dr. Govind, because we we want to listen from the specialist mouth, because this is not the area of our concern or cough affecting the incontinence. And to throw us, because most of the pulmonologists are online now, where exactly they have to seek for you?
So definitely, we are all addressing about the multidisciplinary management, because this is very crucial in management of bladder abnormality. This requires a neurological evaluation, because the different anatomies are involved. Na? Because there is respiratory involvement, pelvic floor muscle involvement, as well as the coordination and control part is also involved. So no one can manage it in isolation. No. We were discussing about the gap in current practice. The major gap in current practice is that urinary symptoms are often treated in isolation without adequate evaluation. of the underlying neurological cause. Many patients are labeled having stress or urge incontinence are actually carrying the red flag signs, the neurological red flag signs such as sensory changes, very subtle numbness or paresthesia around the perineal area, which they often ignore, or the associated bowel dysfunction like diarrhea or bowel incontinence as well, or the symptoms like nocturnal enuresis. That is one of the feature of nocturnal seizure as well, because most of the time they are having seizure at the night and they are passing urine or stool in bed. Subtle motor signs like spasticity in the limbs, they are walking slowly, they are feeling stiffness in the limb, which is a very subtle sign of multiple sclerosis associated with the bladder symptom. That is also missed. So definitely urodynamic studies, neurological examination, and the history part, because in the neurology there is a dictum. We are unable to make a diagnosis of 90% by just taking the history, then definitely there is a fault in history taking. I think this is applicable in all the modalities or all the specialties of medicine, but this is often ignored. So proper history taking is also important. Another important gap is the lack of structured multidisciplinary coordination. Follow-up is often symptom-based rather than outcome-based. And insufficient long-term monitoring of renal function or bladder pressure, these all are the current practice gap. So patient education is also very important regarding clean intermittent catheterization, which is often not taken care of. And adherence to therapy is also inadequate because the patient are not very much aware, or the patient education part was lacking. So I think addressing all these gaps will lead to a better society or better medical care, I think.
Thank you, Dr. Govind. I would like to hear from one more specialist out of our pulmonologist. I will come to pulmonologist last, Dr. Janki. So we normally don't refer to pelvic floor exercises and all. Our physiotherapies are more chest physiotherapy, postural drainage for bronchiectasis, and post-tracheostomy care, and cough stimulations, all those things. We normally don't ask for those things. So pulmonologist may not directly refer to you for these tests. Which are the areas where we should think of physiotherapy when we are dealing with your cough? You can address the cough, it can address the incontinence. Those kind of patients only can come to you in routine practice. So they may not come for the gynec. They will come through a gynec route. How exactly
Yes.
we as a pulmonologist, when you are addressing a cough symptoms, you can utilize your service and incorporate routine practical clinical managements of our patients?
I think the major gap in this area is regarding the awareness. So we can spread awareness by social media advertising or via public talk, so that the patient or the people will get more aware regarding this, and even they can educate these things to their family members. Other than that, we can advise patient to incorporate into low impact aerobic exercises like yoga, swimming, that will strengthen the core muscle, and that prevents the this situation or incontinence. And other than that, lifestyle modifications, as madam has said, weight management, then less intake of caffeine, or along with this correct use of sitting posture, that also decreases the pressure, and that also helps to prevent the incontinence.
Okay. Thank you, ma'am. Thank you very much. And I would like to come to a pulmonologist since the platform for pulmonology, and I would give thank you for all the panelists, neurology and gynecology and physiotherapy. I would like to come to Dr. Yash Rana, who's better off as this physiotherapist. And pulmonologists, when we are addressing the incontinence, we should ignore certain symptoms, or we should give importance to those symptoms. Sometimes they will tell about numbness on the legs. We miss DVT and pulmonary embolism. We ignore certain things because when they are taking history, we are in the fast in OPD, this thing. So sometimes we ignore when they're in the presence of their husbands. So they don't come up. They come with the parents or the mother, they may open up.
Right,
So
sir.
we should highlight those symptoms. We should catch those symptoms when they are history taking, and that's really important, sir. It is submerged in the eyes. Certain symptoms we can't ignore. Which are the things when you are taking the history in a cough and nonsense, we should ignore sometimes. Certain we should highlight and dig deep. Those are situations. Which are the conditions which you really go into asking more and more history. Sometimes This will stop.
Right. So whenever we are taking the history, actually, I would recommend that we should give proper an adequate time to listen the patient first, and then whenever we feel that there is lack in proper points which have patient may associated complaints of this kind of urine leakage or anything else, that we should where we can ask in a in a simple way, like if we cannot straight away ask for urine, but if patient is facing some difficulties while coughing, what are the associated complaints? If they have the clothes may get dirty, in a simple word, like why this reason is like we don't know whoever the relative is accompanying the patient, and in front of that relative, whether it is first generation or second, patient is comfortable to answer everything or not. So we try to dig out everything when we are taking the history. Always, I would recommend to give proper time to ask associated complaints, and we should do this always. Otherwise, we will miss this kind of issues, and patient will not get such benefits by visiting a doctor. Another thing is where a multidisciplinary approach, which is already ongoing right now. Whenever I observe such kind of complaint from my patient, I would definitely recommend my patient to and refer to a gynecologist if she is female, and whatever history he or she is facing. So, and then I call the referral doctor also. That sir, these are the complaints, or ma'am, these are the complaints. Whenever you see the patient, just whenever you are free, let's have a discussion on this so we can go to a same page. So it's a good practice to do every time if it is possible in your running OPDs. But take out at least 5 to 10 minutes in such patients. When you see the patients are very much anxious regarding the cough, there is something which are still not given a proper history by them. So at that moment, we should emphasize more over the history.
Thank you, Dr. Asha. Would you like to add anything? You're mute. You're mute. Can you unmute?
Yeah. Okay. So what I would like to say is like basically when we reach some optimal level of medications, and still if the patient is presenting with cough, and we do think of more towards the psychogenic. So before labeling anything like that, our history should be towards eliciting any kind of organic lesions. And as sir said, MDT discussions for cough, I don't think so it's happening routinely. But if it is so many lesions won't be missed out.
Yeah. Most of the time the patients will come here, you need one, there's no single brahmastra, there's no magic drug that cough will go, you give one drug and it will go. So cough sometimes may persist for 3 weeks. So without waiting, they keep on taking antibiotics every day, every do, and sometimes they were taken in 3 days 5 antibiotics. So such is the pressure in this COVID. We have seen so much of coughs, and most of the viral coughs are lasting for 3 weeks and 6 weeks. It's really painful to see if all the tests are normal. And sometimes the waiting period, our generation in entering to this thing, the waiting period is very less. They don't they just google, they see a lot of other things, they have complications. Cough can cause rib fractures, cough can cause syncope, cough can cause incontinence. Cough is really a tough symptom to treat. So you may not require much of a bronchoscopy. You may require endoscopy for H. pylori. You may require VLS or vocal cord problem. Cough as a symptom, sometimes in terms of mechanism of a cough, what Dr. Fathima has said, there's no single drug. Their cough research center is there in London. You really get this thing. Sometimes we give steroid, cough suppressants, peripherally acting, centrally acting, linctus codeine, all those things also as a symptom relief we are temporarily used. You need to address the cause. You need to address the reason for cough and diagnose the disease and treat it well. And appropriately address that, your incontinence will happen. There are some cases and subconcept of patients who really have to go to a particular specialist to address it properly. And there are situations we should be aware where for our own family members' sake or for our own elderly patients, or we need to know beside the scope of pulmonologists how exactly to refer appropriately and manage it well holistically. Thank you all. Thank you all. There were 1,985 logins as per Dr. Sri Krishna's message here. Thank you, CCI, and heading to next year on the first day of 2026. We are moving on, and this CME they wanted to come cut short for one and a half hours. I think we have stick down in spite of the presentation 20 minutes. I thank all of you panelists who made it so much interesting and more practical. This is a dry topic. It doesn't have much of a video, more of showing to any surgical skills. It is just a symptom. Thank you all. Thank you
Thank you
all.
so much, sir. Thank you
Thank
so
you
much
so
for this
much.
opportunity, sir.
Thank
Happy
you,
New Year
sir,
to
for this
everyone.
opportunity.